Good afternoon, everyone. Thank you for joining us for oral presentation session 8. My name is Bangul Aung from National Cancer Center, Korea, and the chair of this session. Before starting the presentation, I would like to introduce our speakers briefly. It's great pleasure to introduce our speakers. In this session, we have a total of 9 speakers. We will talk about the bariatric or upper GI surgery. So we have a total of 9 speakers. One, Dr. Yurtgorov from Uzbekistan, and Dr. Ho Jang-sin and Sinu Park from Korea, and then Dr. Rehmet and Ali from Pakistan, and then the Young-Seok Park, Dr. Sang-Moon Ham from Korea, and finally Dr. Chant Wibul and Kong Sa-wat from Thailand. So please enjoy our presentation, and after all presentation, we will have a Q&A time with our speakers. And please feel free to ask our speakers your questions by clicking question button at the right side of screen or by the chat window. Thank you. Please enjoy.
Hello, dear colleagues and families of this wonderful virtual meeting. I would like to appreciate Congress Secretary for the opportunity to present our work. We are presenting our study dedicated to endoscopic characteristics of upper GI tract in children with gliadal malformation. We have nothing to declare. Gliadal malformation is congenital bile duct anomaly with cystic or fusiform dilatation of the biliary tree and have potential for various complications. Most of the reported cases in the world come from Asia. Primary excision followed by biliary reconstruction with hepatic jejunostomy or hepatic duodenostomy, the fundamental treatment for gliadal malformation. There are reports of important postoperative complications such as the duodeноgastric regurgitation. We aim to study the features of upper GI tract after surgical treatment of various types of gliadal malformation in children. 40 children with different types of gliadal malformation included in this study. Gliadal malformation mostly observed in girls. Their mean age at surgery was 5 years. In our study, we used King's classification of gliadal malformation. Pre- and post-operative workup included blood work, liver function test, abdominal ultrasound, MRI, and upper GI endoscopy. According to abdominal ultrasound and MRI, most children had cystic type of gliadal malformation with cystic dilatation of extrahepatic bile duct. It's type 1, according to King's criteria. 4 had multiple cystic dilatation of intrahepatic and extrahepatic bile ducts. Type 4A, according to King's classification. And 3 children had Carolla syndrome. This is association of type 5 gliadal malformation according to the King's criteria and liver fibrosis with complication as portal hypertension, hypersplenism, and esophageal gastric varices. All children with gliadal malformation operated. Children with Carolla syndrome had esophageal varices on upper GI endoscopy, and they had gastroesophageal disconnection procedures such as suture and combined with endoscopic esophageal variceal banding. 4 patients with gliadal malformation underwent hepatic duodenostomy, 7 hepatic jejunostomy. In the current preliminary study, the patient in the hepatic duodenostomy group showed excessive duodeноgastric reflux compared with the hepatic jejunostomy group. This may be explained by the fact that the bile was reconstructed near the pylori so that bile is excreted continuously into the duodenum with no sphincter mechanism. None of the patients with Corolla syndrome has recurrent GI bleeding from esophageal varices. In conclusion, hepatic duodenoscopy has advantages of relative simplicity, shorter operative times, reduces adhesive obstruction, and the potential physiological superiority of bile drainage into the duodenum that may counterbalance the bile reflux gastritis handicap. From the perspective of duodenogastric regurgitation, bile reflux gastritis, hepatic jejunostomy is more preferable for biliary reconstruction following excision of the choladical cyst. Thank you for your attention.
Good afternoon, ladies and gentlemen. I'm Dr. Shin from Ajo University Hospital in Korea. Today I present the long-term comparison robotic and laparoscopic gastrectomy using propensity score weighted analysis. Before start our analysis, let me briefly review the benefit of robotic gastrectomy. Until now, there are 2 randomized controlled trials and 5 prospective studies. However, most studies are based on the single-center retrospective analysis. 2 randomized controlled trials shows that robotic gastrectomy shows less bleeding, shorter length of stay, however, shows longer operation time. One prospective multi-center study from Korea, robotic gastrectomy shows no clear benefit. The benefit of robotic gastrectomy is inconsistent from the study outside Japan. As we can see, the morbidity rate and the blood loss or length of stay are slightly better, but the result is inconsistent. Studies from Japan shows that robotic gastrectomy shows a slightly better outcome in terms of morbidity rate and length of stay. However, the blood loss was not lower and the operation time still longer in the robotic gastrectomy. The long-term outcome is not different between 2 approaches. So we published a paper regarding the long-term outcome of robotic gastrectomy using propensity score weighted analysis. The difference between the propensity score matching and the propensity score weighting is that in the propensity score matching, after we calculate the propensity score, we can choose the control group one by one. However, there are potential drawback of the PSM such as a large number of control group may be needed, and it depends on the specific matching technique, and the large number of control group may not be used. However, if we use the propensity score weighting, we give the more weight to the control group, so we can use all the participants, and the most statistical method can be used, and we can estimate average treatment effect. So as we can see, the proportion of participants are different between 2 groups. However, we can give more weight to the control group. The proportion of participants can be balanced. To calculate the propensity score, we use the graded boost method, which is based on the machine learning technique. For example, to predict the body weight, we can start from the mean of body weight, and you can add the value of the residual multiplied by learning rate, and this slide is 0.1, and we can repeat this algorithm until no improvement. With this algorithm, we can optimize the propensity score, and we can trade off the variance of covariate. Is similar to randomization, so we can minimize the difference in covariate except for the treatment effect between 2 groups. So this is the flow diagram. We include more than 2,000 cases of minimally invasive surgery, and we exclude the mortality and conversion cases. This is the basic characteristic. Before waiting, there's considerable differences between two approaches, such as the age or ASA classification, ASA classification. However, after waiting, the differences were controlled. As we can see, the level of standard mean difference is less than 0.0, 0.1. This is the surgical outcomes. Even after waiting, there are better outcome in the robotic approach, such as the more harvested lymph node in the suprapancreatic area and less conversion rate, and the blood loss was lower. However, the operation time still longer and the robotic gastrectomy. So, and the morbidity and mortality were not different. The complication grades and types are not different between two approaches. Also, the trends of the complication are not different. This is the cumulative surgical outcome. We further analyze these outcome, and this is the blood loss. As we can see, the blood loss was significantly low in the robotic approach from the beginning. Even the gap is narrowing year by year. However, the final outcome is better in the robotic approach. Obviously, the lymph nodes are slightly more in the robotic approach. However, the final outcome are not different. Slide shows the suprapancreatic lymph node. As we can see, robotic gastrectomy shows slightly better amount of suprapancreatic lymph nodes, and the final outcome is better in the robotic approach. However, the operation time is still longer from the start beginning to the end of the study period. Long-term outcome are not different. The subgroup analysis stratified the stage by stage shows no difference in the overall survival and the recovery survival. The progress factor for both overall survival and recovery survival were the number of comorbidity and the level of serum albumin and pathologic stage. And another progress factor for recovery survival was the severe complication rate. So we need to talk about the cost effectiveness of robotic gastrectomy because the morbidity mortality shows no difference. With just better short-term outcome, we cannot justify the wide adoption of robot because the gap is narrowing by year, and there's still unsolved problems such as high cost and long operation time. So for wide adoption of robotic gastrectomy, we need to reduce the morbidity mortality rate. And if we can get more precise dissection with robot, we need to apply the robot to more complex cases such as revision operation or remnant gastric cancer or cases requiring more precise lymph node dissection. And we need to develop more cost-effective robots such as a more handy, more cheaper, or more better ergonomic platform should be invented in the future. Conclusion. With sufficient statistical correction, we demonstrate a superior surgical outcome of robotic gastrectomy, and long-term outcome are comparable to those of laparoscopic gastrectomy. So robotic gastrectomy is a safe and reliable option for minimally invasive surgery for gastric cancer. For wide adoption of robot, we need to develop more cost-effective robot and standardize of operation technique, and the systematic education programs are required for better outcome with robotic gastrectomy. Our institute published a journal regarding the robot and robot-related anastomosis technique. I'm sure that this journal will be the valuable guide to establish the role of robot in the future surgery. Thank you.
Dear professors and doctors, I'm Shin-Hoo Park, the clinical assistant professor in Korea University. Today, I will present the is totally laparoscopic total gastrectomy better than laparoscopy-assisted total gastrectomy for early gastric cancer, a propensity score-matched analysis. The potential advantages with minimal invasiveness of TLTG was reported in many studies. However, intracorporeal esophagojejunostomy has not been fully standardized, and level 1 evidence has not been established by a randomized trial yet. Moreover, the quality of life was not analyzed during postoperative 1 year. This study aimed to compare surgical outcome and quality of life between two groups by propensity score matching analysis. All TLTG cases, including the first case with intracorporeal hemidouble stapling, were enrolled to minimize selection bias. Then TLTG group was 2-to-1 propensity score matched to control cases of LATG group. Hemidouble stapling technique was described as figures. A. Opening of the anterior esophageal wall. B. The prepared anvil with stay suture was inserted through the distal esophagotomy site. C. The needle tip pierces through the medial side of the esophagus. D. The anvil rod can be delivered outside by pulling the tied prolin. E. The distal esophagus was transected by linear stapler above the level of esophagotomy site. F. The anvil shaft was positioned at the tip of the stapling line to form hemidouble stapling. Surgical complication was compared between two groups. And to determine the trends of the learning curve, the Kusum score using the CCI and operation time was calculated. TLTG group, after overcoming the learning curve group, was 2-to-1 propensity score matched again to control cases of the LATG group. Then EORTC C30, STO22, and OG25 were prospectively surveyed during postoperative 1 year. As shown in the graph left side and the table right side, after 2-to-1 propensity score matching, the propensity score, matching variables, and other remaining variables became balanced between TLTG and LATG group. Regarding surgical complications within postoperative 1 month, grade 1 pulmonary complications were significantly lower in TLTG group than the LATG group, before or after matching. The overall rate of pulmonary complications also tended to be lower in the TLTG group than LATG group, but significance was not statistically different. The anastomosis-related complication, including leakage or stenosis, was not different between the two groups before or after matching. As shown in Figure A, the Kusum graph using CCI showed two negatively sloping curves with a negative trend line. The operation time of TLTG group did not show clear decreasing pattern. When the TLTG group was divided by the 26th case rather than another peak point, the CCI, overall complication, grade 1 complication, and grade 1 fluid collection showed a greater reduction in the late TLTG group than in the early TLTG group. So, we define the 26th case as a point of overcoming the learning curve. The late TLTG group had a significantly less grade 2 complication than the early TLTG group, only when the TLTG group was divided by the 26th case rather than another criteria. The late TLTG group, after overcoming the learning curve, were compared with the LATG group before and after matching. After propensity score matching, the overall rate of grade 1 complication, especially pulmonary complication, was also significantly lower in the late TLTG group. and anastomosis-related complications were not significantly different between two groups. The symptom scale with STO22 dysphagia, pain, eating restriction, OG25 eating, and odynophagia were significantly lower in the TLTG group than in the LATG group. ANCOVA analysis could successfully identify the certain time points of significant difference between two groups, and the different time points was marked with asterisks. Multivariate linear regression revealed that TLTG versus LATG was the only common independent factor for significantly better quality of life. Unfortunately, the mini laparotomy wounds of the LATG group are larger and located closer to the epigastrium, while those of the TLTG group are much smaller and located at the lower abdomen. This fact indicates that surgery with upper abdominal incision can induce decreased pulmonary function more frequently. And this is the first study comparing quality of life over consecutive multiple time points during post-operative 1 year. Previous studies reported better quality of life score about C30 pain and STO22 dysphagia in TLTG group, but they only investigated the quality of life at single time points, especially 6 months, and did not include OG25, which can be more sensitive in evaluating quality of life of total gastrectomy. And we analyzed the CUSUM and learning curve based on the CCI, not based on operation time. In the past, standardizing multiple complications into a single variable seemed impossible due to the absence of adequate methods. However, one representative complication index per patient can be estimated owing to the introduction of the CCI. And CCI is directly related to patient's outcome. This approach to learning curve calculation is more reasonable and intuitively understandable compared with previous approaches based on only operation time. So, simple efforts to shorten the operation time can be meaningless during adoption of a new complex surgical technique. In conclusion, TLTG with hemi-double stapling reduced pulmonary complication and provided better quality of life in terms of dysphagia, pain, eating, and odynophagia than LATG.
Hello everyone, I'm Dr. Danish Ali, a fellow surgeon from Lahore General Hospital, Pakistan. I wish you all would be doing great in this era of COVID pandemic, and I'm thankful to the Korean Society of Endoscopic and Laparoscopic Surgeons along with the robotic surgeons for giving me an opportunity to present on this very prestigious forum. And today I'm going to talk about our laparoscopic bariatric surgery setup and experience in a public sector hospital in a low middle income country like Pakistan. Before going to start, I have to declare that I have no personal or financial interest to disclose. And secondly, picture taking is allowed during my presentation, which include even the presentative slides as well. So before going into the bariatric services in our hospital, I would like to tell that after establishing foothold in the West, pandemic of obesity now threatens the developing countries of Asia like Pakistan. And Pakistan has witnessed an unprecedented growth of obese individuals, which is causing a serious public health concern. And we all do know that bariatric surgery is now the established first-line treatment for all these kind of patients. But this has been more constrained to the private setup, and very few who are the rich can afford it. So bariatric surgery in Lahore is a dream for the poor patient. So we being three major public sector hospital in the Lahore city, which is the capital of the province, has started to provide these services to our poor patient. And yes, it was very challenging. It has a lot of limitations like human resourcing, administration issue, team management, as well as the awareness among the uh, population. But even though with that, accepting the challenges, we are providing our services from the last 2 years in a public sector teaching hospital, kind of free of cost. So now I would like to talk about our setup. We started in our services in August 2017. We have two HT laparoscope, and fortunately we have a dedicated bariatric table. Unfortunately, we don't have a standard bariatric MDT, but we make sure that every patient individually seen by the endocrinologist, pulmonologist, anesthetic, and a psychiatrist if needed. So it is a kind of individually based MDT in order to cover all the aspects of a bariatric services. Now comes the very important point aspect of it, which is the cutting the cost, because as we are claiming that we are doing it in a public sector hospital and kind of trying to make it a free for the people, we all do know that this is a private setup. In private setup it ranges between 2.5k, like 2500 dollars to $3500, which has recently risen due to the recent depreciation in the rupee. And also we do know that hospital doesn't charge for the surgery but disposable aren't usually available for these patients. So minimum cost of the disposable, we all do know, ranges between $1500 per patient, which is again too much for poor patient. So we need to improvise how we can. What we can do is to reuse metal ports. We have to reuse some of the energy devices and the stapler guns. I know some of you might not agree with me on this point, but we have to do that for the patient. But this only leaves the cost of the stapler cartridge. Every now and then hospital does approve some of the grant or supply of the staplers and cartridges, but we won't be able to provide completely free of cost services. This is a bitter reality. We have to accept that. So we let the patient decide how much they can afford. Some are ready to buy all the disposable. That's a very good scenario. Some can only buy the cartridges. In this scenario, it would be a mutual journey. Some do end up being totally free. For them, we have to arrange through the donation uh, and other societies to help these poor patients. Recently, we had an experience of cheaper Chinese stapler. We are trying to use them. These are 40% cheaper, and no immediate short-term complaints have been noticed, but long-term results have been available. Now I would like to present my data. It is between Jan 17 to December 19. We have total 42 patients. I know it's a slow accrual, but this had placed a solid ground on which we are going to substantiate the numbers in the future, inshallah. As you can see from these figures that in the very first year we only performed 10 surgeries, but in the next 1 year we have already doubled it, and in next 6 months we have already done 13 patients. Let me tell you that we haven't performed any surgery in this COVID pandemics, but now the peak of the infection is getting low, and we are in a position that to resume our services again for our patients. Number of cases and type of procedures. Uh, as we all know that sleeve is the most commonest procedure, so 32 number of patient underwent sleeve gastrectomy, 5 have Roux-en-Y gastric bypass, 4 have mini gastric bypass, and 1 have redo surgery in which we converted a sleeve into Roux-en-Y gastric bypass. So next is very important, surgeon. Who does the surgery? As we claim that we are going to make it a teaching department, teaching bariatric surgery to train more and more people in this field in order to provide services to our poor patients. So this figure is quite interesting. As you can see, more number of patients have been done by the professor, head of department. Boss is always boss. But the good thing is that almost 50% of the cases have been done by the junior faculty as well. 15 by associate and assistant professor, 7 by the fellow surgeons like me. So we all getting an opportunity to perform, not only just to observe and learn, but also to perform surgery. Outcomes are great in terms of excessive weight loss. It was like 12% 3 months, almost 40% at 6 months, and 60% at 12 months. Resolution of the comorbidities, diabetes almost 90% of the cases, hypertension 90% of the cases, sleep apnea and hyperlipidemia 90% of the cases. No peri-op complications, only 2 minor wound site infections which were with complications. Follow-up we did from second week to the 2 years, and this is quite problematic because patients tend to lose follow-up after a year when they have already lost weight, regardless of the repeated conclusion. As we all know that morbid obesity is a serious health concern in developing countries like Pakistan, and bariatric surgery is the only solution to these people. And we are happy that bariatric surgery in a public sector hospital is now a reality. Though a lot of challenges have to be faced, it requires a lot of continuous improvisation and dedication for which we are there to help, and we hope to make our hospital a center of excellence in a bariatric surgery. I thank you so very much for your patient listening, and Kamasahnida. Thank you.
Good afternoon, everybody. Today's my topic is short-term result of laparoscopic sleeve gastrectomy with proximal jejunal bypass. This is a prospective observational study. I have nothing to disclose. There are two representative bariatric and metabolic surgery procedures. One is sleeve gastrectomy and the other is gastric bypass. As you know, the prevalence of gastric cancer in East Asia, including Korea and Japan, is much higher than US or Europe. Korea has the highest incidence of gastric cancer in the world. The endoscopic surveillance of gastric cancer is impossible after gastric bypass, so sleeve gastrectomy is more appropriate weight loss surgery for Korean obese patients. How about metabolic surgery? It is not clear whether sleeve gastrectomy will be as effective as Roux gastric bypass in diabetic patients, especially with low BMI. So a lot of surgeons believe that gastric bypass is more effective than just restrictive procedure as metabolic surgery, although there is no level 1 evidence to support this. A sleeve plus procedure can be an alternative metabolic surgery to replace gastric bypass in Asia. Sleeve gastrectomy duodenojejunal bypass is a procedure that has both advantages of sleeve gastrectomy, including possible endoscopic surveillance of the whole stomach after surgery, and benefit of Roux gastric bypass, such as foregut bypass. However, DJB has two major weak points. Duodenojejunal anastomosis is a technically challenging procedure, and second one is irreversibility of duodenal transection. Proximal jejunal bypass can overcome disadvantages of DJB. It has a very simple and reversible anastomosis. So, we conducted a prospective observational study of sleeve gastrectomy with proximal jejunal bypass in 2019. 24 morbid obese patients with type 2 diabetes were enrolled. We performed a sleeve gastrectomy using 36 French bougie, and we bypassed small bowel about 250 centimeter. However, we adjusted the length of small bowel according to two principles. The one is normal functioning small bowel length is more than 50% of whole small bowel length, and the second one is absolute length of functioning small bowel is more than 3 meters. The primary endpoint of this trial is 1-year remission rate of type 2 diabetes, and safety endpoint is 1-year micronutrient deficiency. This is baseline characteristics and surgical outcomes. The preoperative mean BMI was 37.3 and mean duration of diabetes was about 7 years. Mean C-peptide level was 4.2 and hemoglobin A1C was 8%. 84% of patients had 3 to 7 points of ABCD score, and 20% of patients used insulin preoperatively. The mean hospital stay was about 5 days, and the mean operation time was about 135 minutes. This is the primary outcome of this trial. The complete remission rate of diabetes at 1 year after surgery was 69%, and the other 30% of patients showed improvement, and no patient used insulin at 1 year after surgery. About 45% of patients showed complete or partial remission of hypertension, and all patients with dyslipidemia showed improvement at 1 year after surgery. Hemoglobin A1C decreased from 8% to 5.9% at 1 year after surgery, and lipid profile also showed improvement. Mean BMI decreased from 37 to 27 at 1 year after surgery. Total weight loss was about 26%, and excess weight loss was about 88% at 1 year after surgery. This is a nutritional safety result. At postoperative 1 year, the incidence of anemia was about 7%. Iron and folate deficiency were observed in about 15%. Vitamin D deficiency or insufficiency was about 70%. There was no vitamin B12 or copper deficiencies, and zinc deficiency was observed in 18%. The prevalence of micronutrient deficiency in this trial was not different from those of previous literature. Sleeve gastrectomy with proximal vaginal bypass is a feasible and effective metabolic surgery for treatment of type 2 diabetes in Asian obese patients. However, long-term follow-up should be required to confirm the safety and efficacy of sleeve gastrectomy with proximal vaginal bypass. Thank you for your kind attention.
Good morning, ladies and gentlemen, and my name is Sangmun Han. I'm working in the Metabolic and Bariatric Surgery Center, Jail General Hospital, Seoul, Korea. In this slide, and you can see that the trend of the bariatric and the metabolic surgery in Korea between the 2011 and 2012, mostly and the gastric banding is performed in the private and the private and the clinic in Korea. And then from end 2013, the banding procedure is steeply decreased, and steeply and decreased, and gradually increased the revision and the procedure. And so we investigated the reasons of the gastric primary and gastric banding removal, and including and the type of the simultaneous and the revision surgical and the procedure after and the primary gastric banding. You can see that the method and the materials after and the ILB from end January 2013 to end December and 2018, and we retrospectively and reviewed and prospectively maintained the data and base and the medical chart. We reviewed and 180 patients who underwent and removal and gas banding with or without and other and revision and bariatric procedure. Uh, we checked and routine and we checked the routine and upper GI series and the gastroscopy, and all the procedure were performed laparoscopically and by the single bariatric surgeon. You can see that in the result at the demographics, and most of the patient in the female, and the mean body weight is 80 kilogram, and the mean BMI is 33. Mean interval to in the revision is 52 months. You can see the and weight loss and change after and primary gas banding, and total and the patient the number is 180 at primary gastric banding. Uh, at the primary gastric banding, the mean BMI is 33 and 0.8 at the revision state and 29.8. And so, and the mean percentage of the excess at the BMI loss is 44.3. You can see there in the reason for in the revision. The main reason is weight loss failure, and is 50 and percent. The second reason is asparagine and pouch dilatation, and the third result in the slippage, and then and the intolerance and the erosion and the asparagine. You can see the reason for and the revision. You can see that the type of the revision we perform and the band removal only as a 76.7%, and the next procedure is a band removal with the sleeve gastrectomy, and the next and the procedure is the band removal with cholecystectomy, and the reposition, replacement, and application, and lower gastric bypass. And so you can see that in the conclusion, the common indication for revision after the primary gastric banding were and weight loss failure, and the pouch or and the spatial dilatation, and the band slipping. The second and 3, 2, and 5 years later after the primary gastric banding, bariatric surgeon make rule and the preparation, the complication, and the reoperation of the primary gastric banding. The gastric banding should not be offered in the routine to and unselected and mobile with patient. Patient should be informed about the limitation regarding long-term weight loss and the complication.
Good morning, Chairman and Co-Chairman. It's honor to be here to present this study. My name is Dr. Sirirapong Chantaviboon. I'm working in King Chulalongkorn Memorial Hospital. Today, I will present our study weight regain comparison of laparoscopic long-wide gastric bypass and laparoscopic sleeve gastrectomy in Thai patients. This is a 5-year of follow-up study. Trend of obesity in Thailand. Thailand has now become one of the countries with the highest prevalence of obesity in Asia, second only to Malaysia. Bariatric surgery is a well-established treatment strategy for obesity after failure of behavioral and pharmacologic weight loss therapies. However, similar to all weight loss intervention, weight regain is still the problem that deleterious effect on weight-related comorbidities. Multiple weight regain definitions reported vary widely across studies. Despite this being such an important problem, there is no consensus on the definition of weight regain. Recent study by Wendy C. King et al. In 2018 tried to measuring weight regain following bariatric surgery that are more predictive of clinical outcomes. Conclusion that 20% or greater of maximum weight loss perform better for association with most clinical outcomes, but this study limits to no type of surgery in sleeve gastrectomy. So we try to compare weight regain between sleeve gastrectomy and worldwide gastric bypass. Total 4 definitions include definition 20% or greater of maximum weight loss in our study. Research question: is weight regain in laparoscopic worldwide gastric bypass lower than laparoscopic sleeve gastrectomy in Thai patients? Methodology: this is a retrospective study from prospective database of Chulalongkorn Obesity Clinic, adults who undergo bariatric surgery in King Chulalongkorn Memorial Hospital during 2003 to 2018. Record weight by in-body composition analysis every 3 months in 2 years, and then record every year. Methodology: 550 adults aged 18 years or older, undergoing a first bariatric surgical procedure between January 2003 to December 2018 in King Chulalongkorn Memorial Hospital. Exclusion criteria: psychosis, revision surgery, altered bariatric procedure, follow-up less than 1 year. Total 322 adults in our study. 86 patients in our study reached follow-up up to 5 years. Definition in weight regain in our study. Definition 1. Regain more than 25% of excess weight loss percentage. Definition 2. Regain more than 10 kg from nadir weight. Definition 3. Regain more than 5 BMI points from nadir weight. Definition 4. Regain more than 20% of maximum weight loss. Result: we enrolled total 322 patients in this study. 185 patients in laparoscopic worldwide gastric bypass, and 137 patients in laparoscopic sleeve gastrectomy. Male is 44.4%, female is 55.6%. Mean age in this study is 36.6 years old. Patients who have diabetes mellitus tend to undergo laparoscopic worldwide gastric bypass procedure, and patients who have congestive heart failure tend to undergo laparoscopic sleeve gastrectomy procedure. Compare procedure between BMI less than 50 and more than 50 kg per square meters. 44% in our study is supermorbidly obese. Most of patients in our study had laparoscopic worldwide gastric bypass more than laparoscopic sleeve gastrectomy. No statistics significant. Most of our patients reached nadir weight in 1 or 2 years after surgery. Result: weight regain compare laparoscopic worldwide gastric bypass with laparoscopic sleeve gastrectomy. Patients who have weight regain start rising in 2nd or 3rd year after bariatric surgery and continue to rise to 5th year. 27% of patients in laparoscopic worldwide gastric bypass and 26.3% of patients in laparoscopic sleeve gastrectomy follow-up reached 5 years. Median of weight regain percentage in laparoscopic worldwide gastric bypass is 13.4%, and 10.61% in laparoscopic sleep gastrectomy. No statistically significant, no difference in weight regain in both procedures at 5 years. Face weight loss percentage and total weight loss percentage in long-wide gastric bypass is superior to sleep gastrectomy during 3 months to 1 year 9 months, but after that, no difference in two groups. Discussions: laparoscopic sleep gastrectomy and laparoscopic long-wide gastric bypass operations are most famous types of bariatric surgery. Patients who have diabetes mellitus tend to undergo laparoscopic long-wide gastric bypass, and patients who have congestive heart failure tend to undergo laparoscopic sleep gastrectomy. Number of weight regain patients is depend on definition. At 5 years, long-wide gastric bypass and sleep gastrectomy no difference in statistically significant in weight regain. Conclusion: weight regain is common after bariatric surgery. No difference in weight regain at 5 years after surgery. Long-term weight regain at 3 to 5 years after bariatric surgery is still a problem. Due to no consensus in definition of weight regain, thus it is difficult to compare. Thank you for your attention.
Sawadee-krap. Good morning, Mr. Chairman and Co-Chairman and all of the audience. I am Gesada Kongsuvat from King Chulalongkorn Memorial Hospital, Bangkok, Thailand. I hope all of you doing well in this situation. My study is evaluation of achievement of target anti-factor Xa levels in 2 regimens of enoxaparin for VTE prophylaxis in bariatric surgery. Before I start, I would like to invite all of you to be in Bangkok. There are so many beautiful places waiting for you when the situation is okay. Let me start from the definition. VTE refers to a blood clot that starts in a vein that includes DVT and PE. VTE are serious complications. Morbid obesity remains an independent risk factor for VTE, with greater than 2 to 3-fold increase if BMI is more than 40. There are many studies that show the incidence of VTE in bariatric surgery. The range is about 0.2 to 5.4. There are so many ways to prevent VTE. The first thing that's very simple and easy is early ambulation. Lower extremity compression is a good choice to prevent VTE too. Pharmacoprophylaxis, even unfractionated heparin or low molecular weight heparin. In some studies, they say low molecular weight heparin is better. But there are so many regimens, as I can show you in this table. In King Chulalongkorn Memorial Hospital, we use single fixed dose of 40 mg subcutaneously 12 hours before surgery, but many studies use more than this. So we review the literature. They use more than 40 mg. So we conduct this study because all of study it comes from the Western country. That the Western country have more incidence of VTE than our Asian country. Our objective is to assess the achievement of anti-factor Xa level for VTE prophylaxis, and as well as the complication. Our study is randomized controlled trial. Our hypothesis is that single fixed dose of 40 and 60 mg provide adequate level of anti-factor Xa level for VTE prophylaxis in bariatric surgery. Why we use 60? The average body weight of the patient in our clinic is about 124. So if we use the weight-based regimen 0.5 mg per kilo, so it's about 60. So we use 60 in our study. The population of this study is from morbid obesity patient in our hospital. The method in this study is divide the patient into 2 groups, receive 40 or 60 mg of enoxaparin. The blood specimen were taken 4 hours after administration of enoxaparin. For anti-factor Xa level, we use sequential comprehensive device in every cassette and also early ambulation too. The adequate level is in this study is 0.2 to 0.5. This is the model of the study. In our study, the patient divided into two groups equally, and we collect the data of anti-factor Xa level and estimated blood loss and post-operative VTE. This table shows you the demographics data. There is no difference in age, BMI, percent body fat, weight, gender, fat mass, and the type of operation. This graph shows you in the blue column is 40 mg group, and in the orange column is 60 mg group. As you can see in the green box shows the adequate prophylaxis level. In 40 mg group, they reached prophylaxis level as 64%, and in 60 mg group, they reached about 88%. So we calculate the p-value is 0.047. The graph shows you the mean of anti-factor Xa level. The mean of 40 group is 0.2, and the mean of 60 group is 0.3. That the p-value is less than 0.01. This table shows you the summarized data of the result. The mean active factor Xa concentration and therapeutic level concentration, as I showed you in the previous slide. Now let's take a look at estimated blood loss. There are 22.8 in 40 group and 28.6 in 60 group, so it's not statistically different. And in this graph, we show you the correlation between anti-factor Xa concentration and BMI. As you can see in the orange slide, there are correlation inversely in the 60 mg group, but not in the 40 mg group. As well as this graph shows you the anti-factor Xa concentration and weight. You can see the orange line. There is correlation inversely in 60 group and not correlation in 40 group. We go to the conclusion. Enoxaparin dosage at 60 mg subcutaneously is more achieve the desired target levels. There are no significant increase in estimated blood loss and VTE event in enoxaparin 60 and 40 mg group. The trend of anti-factor Xa level in 60 group is inversely proportionate to increased body weight and BMI. Thank you for your attention. ขอบคุณครับ
Can I start? 네, thank you for presentation. From now on, we have the Q&A time. This time we have 4 speakers with us. So I want to introduce the speakers. Dr. Ali from Pakistan, and from Dr. Youngsuk Park from Korea, and Dr. Chantawibul from Thailand, and Komsawat from Thailand as well. If you any question, don't hesitate to ask any question. So, any question as well. If you any question, Yeah. Okay, then I speaking for the Dr. Ali. Can you speak up? Turn on your speak. Yeah, thank you.
Yes.
Yeah, Ali, congratulations, your successful the laparoscopic bariatric surgery. Then what is your indication for the bariatric surgery? When do you do the sleeve gastrectomy and when do you do the gastric bypass, please?
Yes. That's a very interesting question, and it will cover basics of usually follow the guidelines from IFSO, and we also follow the Asian guidelines, which recommend that BMI more than 32.5, we have to take the patient and with rest and with along with other comorbidities. But thing is that we put the patients to the diet and exercise plan to see how much they can lose. And when it comes to decide between the sleeve gastrectomy bypass, we look for the comorbidities. The patient who are a bit old and have diabetes, more towards diabetes and hypertension, we usually go for the bypass. And a young patient with less comorbidities, we go for the sleeve gastrectomies. And for patient who are super obese, more than 50 BMI, we try to go for we try to stage the procedures. We like to go for sleeve gastrectomy at the beginning, and then later on we plan for a bypass.
Thank you for your answer. Then I wonder do you decide the operation according to the cost? Because you announced the cost problem. So I think the sleeve gastrectomy has more stapler. So is it the cost affect your decision? Ali, can you hear me?
Cost is one factor. Yes, I can. Can you hear me? Hello? Can you hear me?
Please go on.
Hello?
Yes.
Yes. So cost is one factor for deciding the procedure, and the patient choice and the simplicity of the procedure is another thing. So if you have gone through my presentation, that sleeve gastrectomy is the most commonest procedure because patients tend to adopt the simplest procedure first. So that's the number one thing. And secondly, it's easy to perform as well. So while we are learning and improving our adopt the simple procedure first.
Thank you for your clear answer. Participant, please understand the technical problem. And any question? And then Dr. Young-Sok Park, you did the sleeve plus proximal jejunal bypass, right? Yeah.
Yes, sure.
Do you prefer this procedure than the bypass surgery? Just bypass surgery?
Gastric bypass.
Yes, gastric bypass.
Yes. Yes.
When do you the gastric bypass, and when do you the sleeve plus proximal jejunal bypass?
Actually, I'm doing the just only a resectional gastric bypass. I do not perform the routine gastric bypass because, as you know, the gastric cancer incidence is very high in Korea. So I recommend the sleeve or sleeve plus first to the patient. But if the patient has a very severe reflux symptom, at that time I considered a sectional gastric bypass. But as you know, the GERD incidence is not so high in Korea, and most patients with GERD, their symptom is not so severe. So I think the sleeve gastrectomy is much more prominent to the Korean patient.
Yeah, thank you for your answer. Then do you think the sleeve proximal jejunal bypass reduce the complication than gastric bypass? How about incidence of complication?
I think that the complication rate in after gastric bypass is not so high in Korea because most Korean surgeons they're very familiar with gastrectomy because the gas cancer surgery. So I think that the complication rate is maybe similar between two procedures.
Yeah. So what is the most advantage of this procedure, the sleeve plus proximal jejunal bypass?
I think the sleeve PJB is a good alternative to the sleeve DJB. Yes.
What is the advantage of this procedure?
Because DJB is very it's not so easy because technically it's not so easy because duodenal resection and the duodenal jejunal anastomosis is not so easy, especially in very high BMI patient. So PJB is just transection of small bowel and jejunal. The small bowel anastomosis is very easier than duodenal jejunal anastomosis. So I think it's most yes better than.
Thank you for your answer. Yeah. So, any question? Speakers, please feel free ask each other. Yeah. Any question? The attendee? And then Dr. Chantawibul from Thailand. Can you hear me?
Yes, I can.
Yes. So congratulations your the study. Yeah. So you present the you do the RUI for the patient with diabetes, and if patient have heart disease, you will choose the sleeve, right?
This is a retrospective study.
Yeah.
In our study, we try to choose a shorter operation such as a sleeve gastrectomy for the high-risk patient that have the congestive heart failure. Tend to be.
So in your presentation, actually in Korea, the proportion of sleeve gastrectomy is much higher these days. How about the Thailand? What is the proportion of sleeve gastrectomy among all bariatric surgery? In your presentation, it was very similar, the comparison.
Yes.
Yeah.
Yes. In our center, we do a lot of the laparoscopic low gastric bypass because we have many super obese patients in our center. But in general, other bariatric center in Thailand, about 80% do sleeve gastrectomy first. In overall patient, about 80%.
Yeah, thank you for your answer. Any other question? And then finally, Dr. Konsawat from Thailand. Yeah, can you hear me? And congratulations, you're the randomized controlled trial. Yes. Do you check the anti-factor 10 routinely or only in this trial?
Oh, only in this trial because the
only
cost.
in this trial. You present. Did you check this anti-factor 10 every day, right?
After administration, 4 hours before, 4 hours after administration of enoxaparin.
How frequently did you check?
One time, just only one time.
Only one time. Yeah.
Yes.
Okay. And when did you check the anti-factor 10 after surgery? When? POD?
No. We never check after surgery. We check only pre-op operative, just one time.
Okay. Thank you. So how long did you follow the patients? You mentioned that there was no event of deep vein thrombosis. How long did you follow? How long?
From now on,
months?
it's about just only 1 year. So long
Only
time
1
to
year.
see this.
Yeah.
We will collect in the future. So, but in this study, just only 1 year that we collect.
Yes. Okay. I have one question
Yes,
to
please.
Dr. Kungsawat.
Yeah.
Hello, I'm Young-Sok Park from Korea. So, actually, in Korea, the most bariatric surgeon, they use the compression device to prevent DVT, but we usually do not use the enoxaparin to prevent DVT. So how about in Thailand?
In Thailand, we use sequential compressive device in every case, and plus pharmacoprophylaxis too. In our center, we use enoxaparin, traditionally 40 milligram subcutaneous, one dose, 12 hours before surgery.
So it's your routine procedure?
Yes, the routine is 40 milligram. But in this study, we extend to 60 milligram and find out what the difference.
How about the incidence of the venous thrombosis after bariatric surgery?
In study, there is no DVT of PE, so the incidence in Thailand is very low too. But it's not can exclude the subclinical VTE or PE because we do not do ultrasound in every cases. So we use just only clinical.
How about in
Dr.
Korea?
Chantavibun.
Oh, yes. Please.
Oh, no. I will talk that Dr. Chantavibun, he is the same center as me, so he can help me to answer your question.
Yeah, please. Dr. Chantavibun.
I didn't, in Thailand, it's very low incidence of VTE. I think like Dr. Kisada, I never seen the patient after bariatric surgery have a venous thromboembolism in our center too.
So then, Dr. Young-Sok, how about in your how much the enoxaparin do you use? 60.
I don't use.
You don't use.
Yeah, I don't use.
Okay.
I use only the mechanical compression device.
Okay, pneumatic compression only.
Yes.
Can I make a comment on that?
Please.
Yeah, it's an excellent discussion, and I think it's basically the difference we have is the ethnicity of the people. Usually, the European guidelines they always recommend that you have to go for the VT prophylaxis, DVT prophylaxis, because it's very much common in there. But in our routine practice in Asian countries, like in Pakistan, we seldomly see the patients having DVT due to the surgery. Even patients are so obese, even though we haven't seen not even a single case of it. But though we routinely use anticoagulant like Claxin and Oxaprine post-operatively, we tend not to use it pre-operatively. And like this is a common practice in Asian countries like us, and we haven't seen any cases of DVT. That might be a scenario. But if we would be discussing that in a European station, they would strongly recommend that you should go for DVT prophylaxis because this is quite common scenario in them in USA, in UK.
Thank you for your comment, Ali. Any other questions or comments? Okay, everyone. Thank you for your good presentation, and I really enjoy your presentation. So I'd wrap up this session. The next session will be begin to the 3:40, and please enjoy remaining the session. Thank you. Thank you.
Yeah, thank you. See you.
Thank you. Thank you very much.